So now for our third and final panel, we're going to focus on accelerating recovery from injury. And I'm joined today by three world-leading experts: Dr. Robert Guldberg from the University of Oregon, Dr. Martha Murray from Boston Children's Hospital, and Dr. Michael Longaker for Stanford University. Thank you all for being here. I know this is going to be a great session. And I just want to kick it off with a question for Dr. Murray. From a clinical perspective, what are the major challenges in treating common injuries for athletes at all levels?
Well, that's a great question, Scott. I think one of the major challenges we face as clinicians is that we often don't have a way to measure how an injured structure or a structure that we're trying to train is actually doing. So for example, if a teenage girl is playing soccer, we don't know how much soccer is going to make her ACL maybe stronger or how much might make it weaker, and we have no way to monitor that. Similarly, after we do an ACL reconstruction for a patient, we can't really tell how the graft is doing. So we decide on return to play based on things like the strength of the leg or the knee motion. Without knowing exactly how those injured structures are doing, it makes it difficult to optimize either training protocols or rehabilitation protocols. So something along those lines would be incredibly helpful for us as clinicians.
So, Bob, one of the moonshots for the WUSI Human Performance Alliance is the Regenerative Rehabilitation moonshot. You're leading that. And can you tell us what that is and why physical rehabilitation and regenerative biology need to be considered together?
Yeah, thanks, Scott. Regenerative rehabilitation is really an integrative approach to injury management that recognizes, despite the fact that we've made great advancements in surgical procedures, new regenerative therapies like stem cell delivery and rehabilitation, none of those alone may be sufficient to completely restore function following an injury. And moreover, there's increasing evidence that the combination of regenerative and rehabilitation strategies can be greater than additive. In other words, 1 + 1 can be more than 2 in terms of the patient's recovery by really understanding the principles of how to optimally combine them.
Fantastic. Dr. Longaker, why don't we regenerate? I mean, we rupture a tendon, rupture a ligament, tear a muscle, and we heal imperfectly. It's not as strong, it takes too long. Why don't we regenerate, and what can we do about that?
Well, thanks, Scott. It's a big problem. Scarring is a late evolutionary event. It's a rapid restoration of the body, but it compromises in many situations form and function. So I think it's a speed to survive and procreate at the expense of carefully recreating things. Now, we do have tools and breakthroughs that really raise the specter that this is indeed possible. In the spirit of discovery and then translation, we now know that everyone on this call healed without a scar in your first 2 trimesters if you're injured, and then you transition to scarring late in gestation. So for the first time now, we are able to get wounds to heal with true regeneration without any scar formation, normal strength, all dermal elements coming together. So that's a significant breakthrough in animals, now moving in the spirit of translation, as the WUSI program is talking about, into large animals. So it's definitely possible now to do that outside of the maternal ICU, so to speak. And I think that would be great for all athletes and citizens.
Fantastic. I guess I just want to have all of you look forward 5 or 10 years, and what exciting developments should we expect over the next decade? Martha, you want to take that?
Oh, sure. Yeah. So my hope is that, right now there's a fair number of musculoskeletal injuries that we treat surgically by removing the tissue. So a meniscus tear, we just have to take out the meniscus or part of it. The ACL, we take it out and replace it with a graft. My honest hope is that we'll be able to restore those tissues rather than having to remove them and replace them.
That would be great. Bob, what do you see as a home run here?
I think through this combination of discovery, fundamental, and translation, I think we'll understand more on a patient-specific and injury-specific basis, what is the optimal combination of treatment and rehab. We know this combination makes sense and there's synergy, For example, our lab has recently shown that the timing and the intensity of the local mechanical strains during rehab dramatically affect your genes that are expressed, the revascularization. And so, I like to think of rehabilitation as a mechanotherapy that can be as potent as any medicine and can really be, as Michael was saying, the difference between fibrotic non-functional repair and full regeneration. And what we need to do is really understand what are these windows that are optimal and be able to apply them in a real-time, patient-specific feedback manner. So I think that's where we'll get.
Go for it, Mike.
So we were fortunate to identify mouse skeletal stem cells and human skeletal stem cells in the last 5 years. So a single cell type gives rise to bone, cartilage, and spongy bone. And to what Bob and Martha are alluding to, we've now taken that basic tool and said, oh, can we coach these to regenerate something like cartilage, which has no blood supply and doesn't heal? And the answer is yes, we can do that even in aged animals. We can do it in arthritis. So that's moving into large animals. Secondly, can we use that to understand osteoporosis and osteopenia that happens as we age? And the answer is yes, the skeletal stem cell does participate in that. So these fundamental building blocks can be used to then say, okay, let's not repair with scar. Let's regenerate our native tissue. And I think we're having the building blocks to do that. I do want to add that what Martha and Bob is saying is critically important. What those skeletal stem cells are feeling mechanically or whatever tissue is there is very different from how strong the quad is or the hamstrings are. So I think getting to the tissue that is regenerating and understanding what's happening in an implantable or some new image will really fast forward this. So that's what I look forward to.
Yeah, so you all pointed at this gap of knowing what the mechanical loads are on tissues and how that is a potent medicine for regeneration or not. And what do you see as the interplay between sensors, either implantable or wearable, in the regenerative biology space? Martha, you want to jump in?
Sure. I mean, I think it circles back to what I think we've all been saying, but if we had some way of measuring how the tissue of interest is responding to the mechanical stresses that are being put on it through rehabilitation, that way we could really tune those rehabilitation protocols or training programs to optimize that tissue to make it stronger and stronger rather than having it broken down by our protocols.
Bob, what's up with wearables or sensors?
Yeah, I think it's going to go beyond wearables. I mean, as has already been talked about, wearables are moving at incredible speed. The sophistication of the type of data that we're getting for these athletes is just, exponentially increasing every day. One of the things that we're really excited about at the preclinical stage right now is we've developed some completely battery-free wireless sensors that can be implantable. So implantables, if you will, that can provide feedback on the inside. So you can imagine someone has a fracture or an ACL reconstruction, and the physical therapist is actually getting real-time feedback of the mechanical environment during the rehabilitation process. And I also mentioned, I don't think it's just sensors. I think what you do, Scott, is incredibly important for understanding what that mechanical environment is, because what we're trying to study, human performance, is incredibly complex. There's way too many variables for us to rigorously test all of them, even if we had 100 years to do it. And so the marriage of experimental studies with computational simulations is so important. And that, the digital athlete that you're leading is going to really marry so well with all the experimentalists and the data they're collecting.
Thanks. Totally agree that we need to marry the experimental and the AI and the simulation. Yeah, I have a bunch of questions now coming in. This one actually came in from Professor Connie Chu, one of my colleagues at Stanford. It was for the last panel, but it's totally relevant here as well. What are some actions that can be taken to reverse osteoporosis? Bob, you want to jump in?
Well, I think certainly, first of all, understanding, as was talked about in the previous panel, what is the progress of the remodeling that's going on, and understanding the mechanics and how we're at risk for refracture is going to be really important. But clearly physical activity is one of the components that's going to be key for maintaining activity. The problem with osteoporosis is, of course, that you're also at fracture risk. So again, it's going to be fine tuning that physical activity to the right level that it's actually enhancing bone density, but isn't causing a potential risk of fracture to the patient.
Another one coming in. I'll dish this to you, Dr. Murray. How might you use the principles discovered about regeneration to actually prevent injuries from happening in the first place?
Well, I think if we can figure out what signals would stimulate a tissue to regenerate, many of those same signals would be the same signals that would encourage the tissues to make more tissue or make the tissue bigger and stronger. So I think understanding regeneration helps us, and also understanding how to build tissues up so that they can take the stress that an athlete wants to put on them.
Okay.
Scott, may I jump in on the osteoporosis question? So
yeah,
one of the people that will be funded, my colleague, Charles Chan, and I have a paper coming out in Nature that explains osteoporosis through changes in the skeletal stem cell, and also talks about a local rescue to restore fragile fracture healing to normal, healthy levels. So again, these fundamental discoveries do have an important role to translate. I want to say that later today and tomorrow, there's over 900 people on a Howard Hughes Medical Institute in Janelia conference that's Replace, Repair, and Regenerate, with the specific question, why don't humans regenerate? So the synergy of this program with other programs is actually happening today. And that just shows you the demand and appetite for people who want to be regenerated back to how they were, and not with a spot weld repair that kind of does it.
Scott, if I could just add to that, one of the things that we've been really excited about recently is discovering that there is an immune component to all this. And a lot of what explains differences between how patients are repairing or having fibrotic repair is their immune response to injury. And what's really been fascinating about this is some of the same responses we're seeing in non-responders to treatment are what you see in a cancer patient or an infected patient. And so there's a lot of crossover between these different fields.
Yeah, I saw you had that beautiful paper in PNAS a couple of weeks ago. I really enjoyed that. Okay, we have a question coming in from Rocky Twan. Rocky, I'm sorry I didn't get to your question last time, but this will be our last question for this panel. Bob, I'll dish this to you initially, and then Mike, you can chime in, anybody else. How do we optimize the interplay between intrinsic and extrinsic factors in regeneration? And with respect to fetal healing, is a key feature of the fetus floating in the maternal ICU that is no weight bearing, or are there other factors to consider? So Bob, why don't you take that and then pass to Mike?
Yeah, great question from Rocky. Thank you for that question. I think this really gets to the patient specificity, understanding what that intrinsic regenerative capacity is, which we don't exactly know how to measure that right now. It might be levels of circulating stem cells, or it might be the vascular the vascular situation for the patient, or their immune status. So understanding that, I think, will help us tune and again do real-time feedback of those extrinsic factors, which could be a treatment or a rehabilitation protocol, in order to optimize it. It's really this combination, I think, that's going to be so exciting to explore through the Human Performance Alliance.
Mike, last quick comment from you, and then I'm going to have to close the panel.
Thank you, Rocky, for the question. It turns out that the hypogravid environment in utero doesn't play a dramatic role in how we heal. However, modulating mechanical responses in adult animals with a certain fibroblast population is the key. So yes and no is the answer. We can't get away from mechanics, which is a foe if you're driving SCAR, and a friend if you're at the right level for hard tissue repair.
Fantastic. Thank you all. Love to work with you. I'm glad that we're going to get to keep this going, and all these discussions many days long over the next few years.